Hello. I am excited to be here. This is an opportunity for me to bring together my interests that are really my most passionate things. I used to work in addiction treatment I worked in a methadone clinic for a long time, and then I was associate director of adolescent programs, outpatient programs, and I study subtle forms of discrimination. So this kind of brings these things together. And called it Kicking Them While They're Down, Stigma as a Barrier to Responding Effectively to the Problem of Addiction. In our society, stigma, which is social devaluation, discrediting, and shame, is ascribed to people with addiction. We all know what the social construction is of stereotypes we have labels for them. We know when we hear druggie, dope fiend, junkie, conjures an image, we know exactly what that means. Well, it conjures these stereotypes that lacking moral compassion, don't care about consequences, disinterested in change, worthless, useless. These are the stereotypes. We all know what they are. And the response that people tend to have, it elicits fear, disgust, anger, hatred, violence even, and sympathy, parentalism, charity. It really serves to perpetuate the devaluation of people with addiction. So my 3 goals in this presentation are to first challenge the assumptions and stereotypes and elicit empathy and compassion for people with addiction, understand how stigma perpetuates marginalization and discrimination for people with addictions, and consider what helps to promote recovery and how stigma is a barrier. So starting with the challenge, that is to challenge the assumptions and stereotypes and elicit empathy and compassion. Addiction can happen to anyone. So people tend to think that addiction is something that happens to other people, but the data shows that it's, in 2012, 8.4% of the adult population. So if you figure that people tend to deny that they have addiction or not be aware that they have addiction or other forms of substance misuse, and that we haven't had a decrease in this issue, you could probably safely say about 1 in 10 people have addiction. Happens in every socioeconomic group, every racial and ethnic group, every gender group, every age group. We all know people who have addictions, whether we know that or not. There are our neighbors, our siblings, our parents, our children, our judges, our doctors, right? We know a lot about what causes addiction. So this is about challenging the notion that they've brought it on themselves. We know a lot about the causal factors. We've been hearing about the ACEs. Most people here are probably familiar with them. These 10 adverse childhood experiences have been shown to predict all sorts of behavioral health problems, physical health problems, including addiction. And the more ACEs, the more risk of developing problematic behavior and addiction. Couple pieces, women with a history of sexual abuse are 3 times more likely to develop addiction. There's an enormous correlation between trauma and addiction. And people with 5 or more ACEs are 7 to 10 times more likely to have addiction. It explains 67% of the variance in injection use, whether or not somebody injects if they have 5 or more ACEs. So, but ACEs aren't the only, we've known there are other risk factors. They're not the only causal factors that we know about. We have a long history of collection of body of literature of risk factors. You can see how the ACEs fit into the risk and resilience framework that organizes risk and protective factors into domains of the social ecology. So the ACEs occur in the family social domain, but there's plenty of others. Lots of them aren't listed here. There's, for example, genetic predisposition would be in the individual domain, low academic achievement at the school level, neighborhood level access to drugs, and protective factors can be organized in the same way. There are factors that reduce the risk of negative outcomes like addiction. And a lot of the literature about what those protective factors are came from studying 4-H, positive youth development. So really, resilience occurs when people do well despite adversity, and sure enough, a lot of people actually can recover, be in recovery with addiction. The more risk factors and less protective factors, the more likelihood of problematic development. And people who are exposed to these risk influences and not protective ones are likely to have disrupted development. Not having normal attachment as an infant, parents on drugs and neglectful, being sexually abused, chronically hungry, malnourished, lacking love and connection, all can contribute to physiological differences in the brain, and they're going to manifest in social and psychological problems and make people susceptible to addiction. It's not trying to drive home the point. It's really a medical, physiological problem, disease. I did hundreds of biopsychosocial assessments in my work, and they're like laundry lists of these risk factors. Okay, so another point, no one wants or deserves to be addicted to drugs. Anyone who uses drugs or alcohol is at risk of developing addiction, but most people don't develop addiction. Yes, it starts most of the time with a decision to use a substance, but most people make the choice to use a substance at some point. And most people just don't develop problems. Especially in adolescence and young adulthood, risk-taking is developmentally normal. The consequences don't fit the behavior. There's no way that anybody could fathom that they're going to develop an addiction and what that experience is going to be like and how it's going to impact their life. Usually it starts out with recreational use, gateway drugs. People can become addicted quickly or it can take some time, but there's something that happens where it becomes a self-medication and serves as a function. I heard people call it their best friend, which is really symbolic. And then it begins to get more serious and people start acting in ways, start losing friends, start losing money, start losing jobs, and it compounds after that. Becoming addicted, that process exposes people to more losses, more traumas, losses of job, hospitalization, other kinds of diseases compounding. It's no longer a choice. Addiction robs people of their dignity, self-efficacy, relationships, family, connection to community, health, and often being able to realize their potential to contribute. Deception is often a symptom to hide use and protect it, and criminality to support it. That is real. Those are symptoms of addiction. They are also the outcomes of the same risk factors predict criminality that do addiction. Addiction really can derail people from their life path, and we need to be thinking about how we're going to help them find their way back on their path or the new path. Addiction hijacks the brain. It's a devastating disease that causes physiological changes in the brain. Takes over the system, the pleasure response system, same as food, water, sex. We heard people put it this same way, that it can be compared to the cravings of someone on the verge of starvation and dehydration. It's the experience of someone with addiction. Is a physiological survival response. Opioid addiction is miserable. Prolonged use changes the brain on a cellular level. Once people are dependent, they use to feel normal. The euphoric effect doesn't happen anymore. Withdrawal symptoms and cravings can continue for months, even years after stopping use. People who have been on analgesics for a long time have trouble ever getting to a place where they are not super sensitive to pain and emotional and physical pain. And someone who uses after they've been off of it for a while is at high risk of overdose and death. And we've seen a whole epidemic of that. Also, a lot of people are using other drugs at the same time, and especially benzodiazepines are deathly combination. So I'm saying we should resist the moral judgment between innocent victims and druggies. Is another point I want to make. The opioid crisis occurred because there's a huge amount of access to opiates, and people got addicted. So we saw that as the prescription rate was curbed, people stopped overdosing from prescription drugs and started, but we saw an increase in heroin, injecting drugs, using other substances. It's the same sickness. People who would never have used drugs progressed to injection use and other substances. And I also want to drive home that there are some people who might fit very close to what that stereotype looks like, but they might have a lot more risk background, a lot less protective, and really find economic resources, social resources go a long way to help people in their recovery, support people in recovery. So now we're going to work on understanding this, how stigma perpetuates marginalization and discrimination for people with addictions. Okay, so this is really moving into looking at how the concepts of that I might apply also to other kinds of marginalized groups like racial discrimination. It's a similar set of mechanisms. None of us are immune to inheriting bias from our ancestors, institutions, and society. I'm pretty sure that most people attending this summit understand that addiction is a disease and care about people impacted by it, but it's important for us to acknowledge the reality of the hate and prejudice that does exist towards people with addiction. Some people hear about lives lost in the opioid crisis and experience a heightened prejudice. And you'll hear things like good riddance, it's a matter of natural selection. That is explicit bias. Those of us who care and want better for people with addictions are also likely to carry implicit bias, whether we want to or not. Implicit bias are the subtle cognitive processes that we're not even aware of consciously. Derogatory messages in interpersonal exchanges and media deliver constant reminders of what it means to be a person with addiction. This is about that, maybe you've heard the term microaggression. It's got a connotation people don't like, but this is what this is about. So like other marginalized groups, stigma is delivered in a number of forms, and like this occurs in a number of ways, to meaning language like substance abuser and dope fiend. Hear these? Expressions of belief that addiction is a moral flaw and not a disease. Told by a family or boss not to tell anyone in order to avoid shame. Encouraging somebody in recovery to use. Oh, you're not really addicted. You're doing way too well to really be addicted. Assumptions made about criminality. Inappropriate questions about sexuality, drug use behavior. Assumptions about being fragile or not being competent. Asked to events to represent without really being invested or caring about it. Excessive gushing and patronizing. These are things that have been identified through some qualitative research. Many people with addiction experience internalized stigma. Lack of self-control. Self-stigma serves as a force towards isolation and desperate denial that pushes people deeper into the addictive process, and people with addictions feel out of control. That's the definition of it. The addiction drives them to engage in activities they know are despicable, and often turns inward and hate themselves. Experience internalized stigma, scared, disgusted, angry, self-hatred, might become violent or suicidal. This stigma also manifests in systemic, and institutional discrimination. So in the ways that our systems are structured and the practices that we do. And this slide might sting a little because there are probably people in this room like me, we all function within the systems that are in place, the policies that are in place. And with best intention, there are ways that we are perpetuating the way that people with addiction are devalued. So, won't read all of these, but think about, first of all, we know that addiction is a medical problem, but we treat it in a separate system, not well integrated. When there's limited resources, they're usually not allocated towards treating addiction, even though it's killing a lot of people, ruining lives. Criminalization of drug use, that's obvious that if it wasn't illegal, if people had access to the treatment that they needed, would they be engaging in so much criminal behavior, getting to such places of despair? The health insurance system doesn't adequately cover it. People are screened out of employment opportunities. Family members are treated as failures. Clinicians aren't trained appropriately. They think that they're, choosing a way to be a clinician that's where they're not going to encounter addiction, but that's kind of absurd. So dentists and doctors refuse the opioids to manage addiction. Goes on. Even with our best intentions, domestic violence shelter that has policies that doesn't allow for people to stay there who have addictions. That's policy and practices deciding to, you can't be here, you can't be here, you can't be here, you can't be here. And we're not really responding to what we know you need. So now moving to considering what helps to promote recovery and how stigma is a barrier. So what if methadone is substituting one drug for another? Might not be a popular thing to say, but I could not feel more strongly about that. Methadone and buprenorphine are opioids. It is like giving insulin to a diabetic. Once stabilized, treatment can start. Before then, you really cannot help someone even think straight and address their addiction. So the basic process in treatment, hundreds of people that I helped, try to help. They want to come in. They don't want to be on methadone. Nobody wants to be on methadone. Nobody wants to be addicted. They hope that they can come in, detox, and be done with addiction. It just does not work like that. So you try to work on getting up to an adequate dose. Once they're stable, they can't get high anymore, even if they do use, and it's got a longer extended medication, so they don't ever get sick. So being on drugs is like this, and being on methadone stabilizes and evens it out. That's what we spend a lot of time educating people about medicated assisted treatment, working through their own stigma, and then engaging in treatment. And this would be a typical set of issues with someone. They might need to get stable employment, housing, have physical health issues, mental health issues, have other substances that they're abusing most of the time, relationships that are damaged and need to be healed, need to develop a support system. They might have involvement with Department of Child Services and have requirements that they need to fulfill. You have to make appointments here for child services, probation over here, addiction treatment here. It's expensive, it's unrealistic a lot of the time to even be able to get to all of those appointments, and this is while they're in withdrawal. It's impossible. I have an analogy about a friend of mine who's quadriplegic and is determined to walk. He's got all the resources and supports in the world, and he's starting to actually crawl when they said he'd never walk. Well, that is the analogy for somebody with opioid dependence who's had their child removed, had that history of trauma, who then is in a place where they don't have their child with them. This is the crisis and pain that people are struggling with, and they need to be treated like they've been traumatized, with respect and unconditional support. And that's, a lot of the time that's just not the way our system's set up. We mostly more of like punitive, criminalized way. That doesn't mean that people who are in the field working in addiction treatment, I know there are people in here who are doing an amazing job. Judge Sloan is doing an amazing thing using his recovery court in the best way possible for the way that our system operates. But there's got to be other ways. And then the idea is after about a year, at the minimum, start detoxing very gradually. And there's close to 100% relapse if they don't stay for more than a year, and 75% they do. So, stigma is a powerful force that serves as a barrier. Among those who need treatment, very few receive it. That's very well established. NIDA data tells us that. It's really easy to differentiate oneself from or a loved one from the stereotypes. Nobody fits that stereotype and sees themselves that way, or their loved ones. Makes it easy to deny it, not recognize it, not get people the help they need. People from going to treatment, and there's not a huge body of research literature about how stigma keeps people from going to treatment and from leaving treatment, and the stigma that people encounter at treatment from providers, from the people who are trying to help them. About those unintentional messages that might be going to a meeting, kind of coming to terms with needing to be on methadone, and then going to a meeting where it's an abstinence only. You can't be here because you're not really clean. There's a quote from one of the qualitative studies about a reaction that a physician had to being on methadone, just like a shift in their, got a moral judgment about being on a life-saving medication. Doesn't really make sense. Okay, so we need another point, to get away from recovery versus program. You can't hear me. Moreover, people with addictions need to find that the changes they make are going to lead them on pathways to well-being. There have to be pathways to people being able to get better, and it can't be like, oh, you get clean first, and then maybe you get a life. We have to figure out ways for people to be able to live with addiction and function and be part of our community. These are members of our community. We need to make room for them, find place for them everywhere, not continue to push them out of everything. The innovation and broad community commitment needed to reverse trends is possible only when we stop allowing moral judgment towards addiction to drive treatment and policy decisions. and instead focus on the reality of the nature of addiction and the worth and potential of people suffering from addiction. Ridiculous amount of unrealized contribution to our society. People are much more than their addiction. I'm not saying that we're ready in Knoxville to make heroin legal, but I'm just showing you one other way that people think about it, right? They're getting ready to, in Norway, they're getting ready to launch decriminalized drug use, and in the Netherlands, they have public injection sites for heroin. So you have an addiction, then we're going to make sure that you have access to being well, and it reduces crime. It's a harm reduction model. It reduces crime. It lets people function more. It's not a cure for their addiction. It's about being able to live with it, live with addiction, with chronic illness. Some people need to be able to have that option. It's not realistic for it not to be so. So I'm just showing you that there's another way to think about it, right? We are operating within certain structures and practices, but there are other ways to do it, and we need to think outside the box. Okay, so last slide. When the community decides addiction is not a moral issue, and people with addictions are part of the community, then treatment will involve people with addictions, first of all, in developing the approaches. Like, we should be seeing a whole lot of people who are in need of treatment saying what treatment should look like, and being the face, like we're starting to do, to help educate. We need to respond to people with love and empathy, make long-term MAT available as a standard treatment plan. So that doesn't mean it's going to be for everyone, but that is the gold standard. SAMHSA drives it home. This is not just an opinion. This is like every expert in a scientist have arrived at. This is where the most evidence is. Develop policy based on realistic expectations of the course of disease, require health insurance to cover it, educate the public about it, train the treatment workforce about addiction, stigma, discrimination, and how to change bias across all different disciplines. Develop best practices for how to support people with addiction in every system. For example, employee assistance programs in the labor force, high schools and colleges, and then prevention. I always come back to prevention. When we'll talk honestly with children about drugs and alcohol, like we're seeing 4-H is doing that program. 4-H is one of the model programs for putting things in place that promote protective factors. We can grow those at our kids in universal programs in schools. After school programming. There's some that have a substantial amount of evidence behind them. They involve multi-systems, engaging family, youth in schools, social emotional learning like the BOPFN life skills, and positive youth development. And trauma-informed care, I think, is very promising. I don't think we don't have the research yet, but we should. I know we're starting to implement that. I'm really excited about it. It just makes sense that we respond to kids with behavioral problems, recognizing that there's probably some ACEs happening at home. And university community collaborations to build further evidence of what works in our unique context in this community and disseminate nationally. Thank you so much. I appreciate your attention and attendance. Thank you.